Hello, everyone. I'm Yiwen. I'm a second-year PhD student, and today I'm going to introduce a project using machine learning to identify cost-effective pre-screening policy for chronic kidney disease. First, I want to give some background on chronic kidney disease. It is a chronic condition referring to gradual loss of kidney function, which currently affecting over 30 million of Americans, and it is a major health burden. The nature of this disease to allow CKD to develop undiagnosed and no symptom until severe stages. However, severe stages of CKD can lead to end-stage renal disease, which means you have an acute kidney function loss, and you will often use dialysis or like you need kidney transplant to keep your survival. And it is not only very deadly, but also create a huge economic burden. We can see that the non-ESRD CKD cost alone accounts for over 20% of the total Medicare expenditure in 2018 alone. And with the ESRD, it's really created a huge economic burden. And with that, it is also the ninth leading cause of death in the US. However, the current status quo policy only screen annually for diabetic and hypertensive patients. However, there is a large portion of population within the diagnosed CKD patients that are actually non-diabetic or non-hypertensive. So in this project, we aim to develop a high-performing at-home pre-screening risk prediction tool with machine learning algorithms. And because there's a lot of thresholds associated with the pre-screening tool, we want to find the best or the optimal threshold to implement in practice. And we can prompt the health outcome, and also we will avoid the excessive spending on the medical costs. And we will do this analysis using the cost-effective analysis framework. And here I'm showing the current status quo policy, which is just a broad class guideline. As we can see along the streamline, only patients who are hypertensive or diabetic will be prompted to a medical screening, and those who diagnose will be put on treatment. However, within the non-hypertensive and non-diabetic group, they will never be treated and never be screened. With our pre-screening tool, sorry, if I pause. Oh, sorry, it just froze. Okay. Oh, okay.
Think you're out of battery.
Yeah, sure. Thanks. So with our proposed pre-screening tool, it's actually prompts those individuals who are at risk within the non-hypertensive and non-diabetic group to undergo the medical screening, and those who are originally untreated individual will be put on treatment. And in order to develop this machine learning tool, we are using the minimal health information, which only 7 variables, including age, race, etc. And this is an online individually targeted screening tool, which screen everybody annually. And here we included 5 different models that we selected for developing this pre-screening tool. After we developed this screening tool, we actually observed there's a bunch of achievable sensitivity and specificity thresholds that we can obtain from this tool. So this is from along the ROC curve, and we evaluate the different performance using the area under the curve, also known as AUCs. So ideally, we want to capture the CKD patients early for treatment, which means we need a high sensitivity. And also we want to save the unnecessary costs, which we need high specificity. However, this might be unrealistic to achieve like 100% sensitivity and specificity. So find which pair will be practical to implement in practice. We will need a cost effectiveness analysis to evaluating those pairs we achieve from the machine learning tool. Here we develop our microsimulation to evaluate the cost effectiveness of each pair of sensitivity and specificity. Here I'm showing that the individuals in our microsimulation can transit to next stage, or they can progress and transit to each stage. And this model is stratified by age, race, sex, and health condition. People on treatment and not on treatment will receive different progression rates in terms of their CKD. Here I'm showing some results first from our machine learning tool. There will be different points along the ROC curve. And with the implementation of microsimulation, we evaluated those pairs and we find that only points lie within the cost-effective region will be cost-effective to implement in practice. So within this region, we pick a point that is maximize the accuracy, and we indeed observe that it increased the incremental net monetary benefits for over $800, which just means that we obtain the better health outcome with less money. And with this framework, we can also save up to 18% of the current USRD cases. So in conclusion, this tool can improve health outcomes and reduce the cost, and points within the cost-effective region will be outperform the current status quo policy and receive a better outcome. And also this framework will allow for flexible policy, which means that they can choose their threshold and understand the feasibility of these tools with the simulation we provided. Thank you.